All right, so a very good evening, everyone. So, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So, in this session, I'll be just discussing some of the important topics in the general medicine, which are very, very important for you from the INICET point of view. Okay, so I'll be discussing many of the clinical based questions, which keeping in view of the INICET exam. So in the INICET, many of the questions or majority of the questions, either it will be like clinical based or integrating, or you'll be having the questions integrating with the basic subjects. So taking that points into consideration, I have framed some questions which we will discuss now. So yeah, so good evening, Khan, and good evening, Falconetti. Right, let us start with the session now. So first will be the cardiology topics, right? So in the cardiology topics, the right, yeah. So in the cardiology topics, the one which I'll be discussing first will be the questions related to the ECG and as well as the arrhythmias. Right. So the first question is, we have a 65-year-old male presents to the clinic for a routine checkup. Right. So this patient came for the routine checkup, and during the examination, his resting heart rate is found to be 70 beats per minute and his blood pressure is within the normal limit. The physician notices that the duration between the P waves and as well as the QRS complex on the ECG is consistently prolonged, which is measuring around 0.24 seconds. Which of the following is the treatment of choice for this patient? No specific treatment. Digoxin, amiodarone, labetalol has to be given. Yeah. Yes. So good evening, everyone. Yes, please answer this question. Just 1 minute. All right, very good, Manish. So this is a first degree AV block. So if it is a first degree AV block, like what is the treatment that you want to do in this patient? Do you want to give any particular drug, or do you want to observe, or what exactly you want to do with the options which has been given to you? Very good. So now this is a case of a first degree AV block, right? So this is the previous INICET question, but in the previous, I think, a recent NEET PG question also, but there the question which has been asked is, they have directly mentioned the PR interval, right? The PR interval they have mentioned as 0.21 seconds, and they have asked whether it is a normal ECG, whether it is a first degree AV block, whether it is a second degree, or whether it is a third degree AV block. That was being asked. So taking that point into consideration, so now you just see this is a first degree AV block, and in case of the first degree AV block, there is no specific treatment required. Okay, whereas you take the other scenarios, like do we give digoxin in case of AV blocks? We don't give digoxin at all in case of AV blocks. Now in case of the AV blocks, if we give digoxin, it will further precipitate the AV block. So digoxin is completely out of the choice. In any of the AV block, we don't give digoxin at all. Whereas you take the amiodarone. So amiodarone is what? It's a class 3 anti-arrhythmic drug, right? It is not used in the treatment of the AV blocks. This amiodarone, it is a drug of choice in case of a hemodynamically stable VT, ventricular tachycardias. We give this amiodarone. And you take labetalol, which is an antihypertensive drug, which is used in multiple conditions, used in the treatment of pheochromocytoma, used in the treatment of aortic dissection. We also give this in the treatment of pregnancy induced hypertension. So multiple places we use labetalol as antihypertensive, but not used in the treatment of the AV block. In case of AV blocks, if you give this labetalol, it will further precipitate the AV block. So beta blockers or alpha plus beta blockers we don't give, and your labetalol is what? It is alpha plus beta blocker. And at this point, I just want to mention one more important alpha plus beta blocker. Another important alpha plus beta blocker is carvedilol. Now, can anyone quickly tell me what is a clinical condition where we use this carvedilol? Yes. Right, good. So carvedilol, please remember, we use this in the treatment of congestive heart failure. We use this carvedilol. All right. Now let me just give you a quick picture of all the types of the AV block. Like we have a second degree AV block following this. So second degree AV block, again we have two types. One is Mobitz type 1 and the other one is Mobitz type 2 AV block. In case of Mobitz type 1, like what is that you will notice? You will notice that there is progressive prolongation of the PR interval, and you will find that there is drop in the QRS complex. That is what you will observe in case of Mobitz type 1, right? Whereas you take in case of Mobitz type 2. So in case of Mobitz type 2, the PR interval, it will remain constant. It will not change at all. But there is intermittent drop in the QRS complex. That is what is your Mobitz type 2. Whereas you take in case of a third degree AV block, there is no association between the atrial and as well as the ventricular contracture. So the AV dissociation is observed in case of the third degree AV blocks. All right. Now, in case of Mobitz type 1, if the patient is symptomatic, we give atropine, right? And these patients with Mobitz type 2, there is a very high chance that they can go into a state of complete heart block. And these patients also, they will be requiring atropine or isoproterenol. And at any point of time, they will be requiring the permanent pacemaker insertion as well, depending upon the underlying etiology. And in case of the third degree AV block, right, the immediate treatment that you need to do is the temporary pacemaker insertion, right? And following that, depending upon the underlying etiology, the patients may be requiring the permanent pacemaker insertion as well. Okay, so this is the first question related to the ECG and as ECGs and as well as bradyarrhythmia. So ECG is always a stock question in any of the exam, INICET exam or NEET PG exam. ECG definitely it will be asked, right? Now we will move on to the next question. Okay, so another important area where the questions are being very frequently asked in the NEET PG is the rheumatic fever. Okay, and in rheumatic fever, that too, in which part of the rheumatic fever the questions are being concentrated is the treatment part. So in the treatment part, like because it being a recurrent fever, we give injection benzathine penicillin. Now you see this question. We have a 10-year-old child presents with fever and as well as the skin rash on the chest. There is a pansystolic murmur that is at the cardiac apex on auscultation. Investigation revealed elevated inflammatory markers and evidence of recent streptococcal infection. The child is diagnosed with acute rheumatic fever. Which of the following statements regarding secondary prophylaxis, right? Which of the following statement regarding secondary prophylaxis for this condition is true? Yes. Now you go through the options once quickly. Injections are given up to at least 21 weeks of the age or minimum of 10 years after the last attack, whichever is longer. Second option, injection are given 21 years of age or 5 years after the last attack, whichever is longer. Third option, no prophylaxis is required as the disease is already set in. Fourth option, the duration of antibiotic prophylaxis is till 40 years of age or 10 years after the last documented attacks, whichever is longer. So what do you think is the correct answer here? Now, what is happening in the recent exams is the topics are same. There is no change in the important topics, but what they are changing is they are changing the options. They are giving lengthy options and they are trying to test your patience level. And you need to be highly patient whenever you are giving the exam in order to read the options properly and thoroughly without any stress. That is a very, very important part of your examination, right? So anyone want to make an attempt? Now, so I'll just crack this question now. So now you see this patient, what category of the patient he is coming under? Actually, we categorize the patients of rheumatic fever into rheumatic fever without carditis, then rheumatic fever with carditis with persistent valvular disease. That's the third scenario. And the next important is carditis without residual valvular disease. Now, which category does our patient comes under? Our patient comes under the carditis with persistent valvular disease because our patient is having a pansystolic murmur. Now, the presence of the pansystolic murmur with rheumatic suspicion, what it could be, it is suggestive of the mitral regurgitation, right? And that too, I'm using the word pansystolic murmur. So if it is a pansystolic murmur, it should be a chronic MR. It should not be an acute MR. Please remember, in case of acute MR, the murmur that you will have is the early systolic murmur, right? The murmur that you will have in case of acute MR is the early systolic murmur, whereas in case of chronic MR, you will have pansystolic murmur. And what is the differential diagnosis for the pansystolic murmurs? The differential diagnosis for the pansystolic murmurs include number one, mitral regurgitation, tricuspid regurgitation, and as well as VSD. But this particular VSD, it should be a large VSD, not even a small VSD. If it is a small VSD, again you will have early systolic murmurs. And even the MR also, if you see, it should be chronic MR and chronic TR. That is when you will have a pansystolic murmur. Now, coming to this particular question particularly, so this patient is having carditis with persistent valvular disease. What is the persistent valvular disease? The patient is having a chronic MR. Now, in case of a chronic MR, how long you give this prophylaxis is the basic question. Now, by observing that there is pansystolic murmur, you need to imagine that there is a presence of a persistent valvular disease. And if you cannot make out that the patient is having a persistent valvular disease, then there is a very high chance that you will land up in the first option, right? But let me tell you, the answer is not the first option. The answer is very good, Mohammed Imran. So the answer is D. The answer is D here, right? So I'll just show you this particular table, and please tell me what is the prophylactic antibiotic that you will give. What is the prophylactic antibiotic that you will give? So please remember, the prophylactic antibiotic that we give is benzathine penicillin, and you should know what is the route of administration of this benzathine penicillin also. Now, yes, this table is very, very important, guys. You need to know the rheumatic fever prophylaxis, how long we give. So the prophylaxis is by your injection benzathine penicillin. Now, if the patient is not having carditis, then you need to give this injection benzathine penicillin until 21 years of age, or right, until 21 years of age, or for a minimum of 5 years after the last attack, right? For a minimum of 5 years after the last attack, whichever is longer. That is very, very important. So that is without carditis. But whereas now, what is our present question? Our present question is, right, our present question is carditis with persistent valvular disease. So whenever there is a carditis with persistent valvular disease, prophylaxis continues until 40 years of age or 10 years after the last documented attack, whichever is longer. So that is what our clinical scenario is. That is, the patient is having pansystolic murmur. Whereas if the patient is having carditis without residual valvular disease, then in such case the patient has to receive the prophylaxis, right, up to 21 years of age or for a minimum of 10 years after the last attack, whichever is longer. Now the question also can be asked, if the patient is allergic to penicillin, then what is the alternative drug that you need to give? If the patient is allergic to penicillin, please remember the drug that we need to give is the macrolides, or erythromycin can be used as an alternative drug. Okay, so this is about the secondary prophylaxis in case of rheumatic fever. This table is very, very important from the INICET point of view, right? Now, after having discussed about the prophylaxis in case of the rheumatic fever, now this is the next important question related to cardiomyopathies. So another important area where the questions are being very frequently asked in the cardiology is the cardiomyopathies. And mainly to grab your time or to test your patience, they'll give you these type of MCQs in the form of match the following. And you need to be very quick in answering these questions. Yes, please answer this question. So we have a hypertrophic cardiomyopathy, dilated, restrictive, and Takotsubo. And on the right hand side, you have the dicrotic pulse, S3 gallop, pulsus bisperiens, square root wave sign, and history of spouse death. Right. So please match the following. Okay. So if you see here, the hypertrophic cardiomyopathy, right, very good. So hypertrophic cardiomyopathy, you will have the pulsus bisperiens, right? And next is, yeah. So, and next is, you take the dilated cardiomyopathy, you will have the dicrotic pulse. Then you take the restrictive cardiomyopathy, you will have the heart failure, and there can be presence of the S3 gallop, or even the restrictive cardiomyopathy, you will also have this square root sign. That is very important. Otherwise, S3 gallop can be present in all the forms of cardiomyopathies. It can be there even in dilated, it can be there even in case of restrictive cardiomyopathy also. Whereas Takotsubo cardiomyopathy, it will go with the history of the spouse death. Okay, so the answer here is the hypertrophic cardiomyopathy, you will have pulsus bispherians. Now can anyone tell me quickly what are the differential diagnoses for pulsus bispherians? What are the other conditions where you can have the pulsus bispherians? Anyone? What are the other conditions where you can have the presence of pulsus bispherians? Very good. So pulsus bispherians is present with AS with AR. Then pulsus bispherians is also present in case of isolated severe AR. Pulsus bispherians can also be present in case of the hypertrophic obstructive cardiomyopathy. So these are the conditions where you will have pulsus bispherians. Whereas you take dicrotic pulse. What is the meaning of the dicrotic pulse? It means that there is one peak in systole and another peak in diastole. That means you have two peaks. That is what is called as the dicrotic pulse. Then what is your pulsus bispherians? Pulsus bispherians is that which is characterized by presence of two peaks in systole. That is what is called as the pulsus bispherians, right? Now what about S3 gallop? Remember, whichever condition is causing heart failure, you will have the presence of the S3 gallop. Now coming to your square root sign, what are the conditions where you'll have square root sign? So remember, the square root sign, it is not just present only in case of restrictive cardiomyopathy. Square root sign is also present in cases of the constrictive pericarditis, and the square root sign is also present in patients with restrictive cardiomyopathy. And remember, your square root sign, it tells you that the pressure changes which are happening within the ventricle, that is being monitored or measured by the catheter in the ventricle. That is what is your square root sign. So square root sign is nothing but the pressure changes that you have in the ventricle, that is monitored or measured by the catheter, is what is called square root sign. Now in case of Takotsubo cardiomyopathy, very important, there should be a history of a mental stress. A history of a stressor should be there in case of Takotsubo cardiomyopathy. Now can anyone tell me quickly what are the criteria? What is the name of the criteria for Takotsubo cardiomyopathy? Any one of you please? What is the name of the criteria for Takotsubo cardiomyopathy? So the name of the criteria for Takotsubo cardiomyopathy is a modified Mayos criteria, right? Now, what are the points in your modified Mayos criteria of your Takotsubo cardiomyopathy is, number one, ECG should be showing the ST segment elevation, right? And troponins should be positive. That is the first important thing. And second important thing is that these patients will be having a 2D echo that will be showing you hypokinesia, right? That will be showing you hypokinesia. That is the second important finding. And the third important finding is that because the first two findings, it mimics myocardial infarction, but the point is your coronary angiogram should be absolutely normal, right? Coronary angiogram should be absolutely normal. Whereas in case of myocardial infarction, what is that you will observe? You will notice that there is presence of an atherosclerotic plaque in case of MI. But whereas in Takotsubo cardiomyopathy, the CAG should be absolutely normal. And the fourth important criteria in case of Takotsubo cardiomyopathy is you need to rule out the pheochromocytoma. Right, you need to rule out pheochromocytoma, because in Takotsubo cardiomyopathy you are having this apical ballooning, or your stress cardiomyopathy is due to what? It is mainly due to release of the catecholamines. Okay, so you need to rule out the pheochromocytoma as a priority. So these are the criteria that you will have in case of Takotsubo cardiomyopathy. And in case of Takotsubo cardiomyopathy, what is the treatment that you need to give? The treatment that has to be given is similar to that of your coronary artery disease, wherein we give aspirin, right? Wherein we give aspirin, right? And we also need to give the beta blockers if the blood pressure is within the normal limits. And what are the drugs which are contraindicated in these patients is the inotropes are contraindicated in patients with the Takotsubo cardiomyopathy, because Takotsubo cardiomyopathy itself is due to excessive release of the catecholamines. So you cannot give the catecholamines in these patients. If at all, if these patients are landing up in a cardiogenic shock, then what is the treatment that you need to do is you need to place the individual on the intra-aortic balloon pump. Okay, so that is what is the treatment for if Takotsubo cardiomyopathy if they are developing cardiogenic shock. Okay, so that was related to cardiomyopathies, and you should not miss the discussion related to your cardiomyopathies at all. That's a very, very important topic in the INICET. Right. And another area where the questions are being asked very, very frequently is about the conduction defects. Okay, the conduction defects. Now you see this question. We have a 65-year-old male with a medical history of the hypertension, right? Medical history of the hypertension and ischemic heart disease. Presents to the emergency department due to intermittent fainting episodes. He describes feeling dizzy and lightheaded before losing consciousness, and each episode it is lasting for few seconds. His heart rate is slow with irregular rhythm. The ECG shows the episodes of the AV block. What do you think is the most likely diagnosis in this patient? Right. So please answer this question. So the patient is having a loss of consciousness and each episode is lasting for few seconds and his heart rate is slow and an irregular rhythm. So what is the most likely diagnosis? Atrial fibrillation, Stokes-Adams syndrome, ventricular tachycardia, and then the supraventricular tachycardia. Right. Yes. Now, so very good. So the answer here is great. That is the Stokes-Adams syndrome. Now, what is the point telling you it's a Stokes-Adams syndrome is that the patient is having, right? The patient is having loss of consciousness, and this particular loss of consciousness, it is lasting for few seconds, right? There is transient loss of consciousness. Why is that? That is due to sudden and temporary interruption in the heart's electrical conduction, right? And in case of Stokes-Adams syndrome, where exactly will be the pathology? It is caused by advanced AV nodal block. It is caused by advanced AV nodal block, and this particular Stokes-Adams syndrome, it is associated with other bradyarrhythmias also. It can be associated with sick sinus syndrome. It can also be associated with the complete heart block, right? And it can also be associated with severe AV conduction disorders. That will be your Stokes-Adams syndrome. And what will be the clinical presentation in Stokes-Adams syndrome? That is syncopal episodes or fainting episodes will be there in these individuals, and the heart rate, they'll have bradycardia. They'll have bradycardia. Okay, then how will you diagnose this Stokes-Adams syndrome? Is you need to do Holter monitoring. So Holter monitor is the one which will help in diagnosis of the Stokes-Adams syndrome. Okay, and even you can do echocardiogram or even other cardiac imaging also may be helpful. That is to assess the heart structure and as well as the function. But the preferable way by which you can diagnose is by Holter monitoring. And now if you see the treatment, how is that you will treat in acute episodes and how is that you will treat in the long term? See, in case of acute episodes, you need to give atropine. Right, in acute episodes, you need to give the atropine or you need to give the isoproterenol may be administered. That is mainly to increase the heart rate. Whereas in long term, right, whereas in long term, these patients will be requiring the pacemaker. So that is about the treatment of your Stokes-Adams syndrome. Then how will you rule out the other options? If you take the other options, you take the atrial fibrillation. They don't present with the transient loss of consciousness. See, they present with palpitations. They present with palpitations, or they directly present with a cardioembolic stroke, that is ischemic stroke, that might be causing your hemiparesis. That will be your presentation in case of atrial fibrillation. And in ventricular tachycardia, they don't have this transient loss of consciousness. They present with palpitations, and even your supraventricular tachycardias also, they present with the palpitations. So a very important area for your INICET revision is your brady and as well as tachyarrhythmias. You should not go to your INICET exam without revising these topics. Okay, next question. Right. Now, the other important area where the questions have been concentrated in the cardiology are the congenital heart diseases. And that too in the congenital heart diseases, which congenital heart disease is very frequently asked, I'll tell you. So we have a 6-month-old baby is brought to the clinic by his mother who noticed his lips turning blue whenever he cries, right? So lips turning blue, he cries or gets sick. and she says that the squatting position relieves the bluish discoloration. Right, this word is very very important, and this is a very very important stock question. Okay, the pregnancy and birth were uncomplicated. Examination revealed harsh holosystolic murmur at the left parasternal area. His complete blood count shows the hemoglobin of 11.2. What is the underlying defect that you observe in this patient? Yeah, so what do you think is the answer here? Great. So the answer here is the cyanotic congenital heart diseases. Cyanotic congenital heart disease. And what exactly is the cyanotic congenital heart disease that this patient is having? Can anyone tell me which cyanotic congenital heart disease is this patient having? Because cyanotic congenital heart diseases, if you see, like we have multiple cyanotic congenital heart diseases, like tetralogy of Fallot, tricuspid atresia, transposition of the great arteries, right? Truncus arteriosus, total anomalous pulmonary venous connections. So these are the various cyanotic congenital heart diseases. Okay, very good, Anurag. So this patient is having tetralogy of Fallot. Now, how is that you are able to tell that the patient is having a tetralogy of Fallot? Is by the presence of the harsh holosystolic murmur. Now, in a case of tetralogy of Fallot, the presence of the harsh holosystolic murmur, what is it suggestive of? It is suggestive of the presence of the ventricular septal defect. And at the same time, you need to know what are the components of the tetralogy of Fallot. So, the components of the tetralogy of Fallot, they include the ventricular septal defect, and it is because of the ventricular septal defect the patient is having your pansystolic murmur. Then pulmonary stenosis, overriding of aorta, and then right ventricular hypertrophy. Now to this particular tetrad, if you add ASD, this becomes the pentology of Fallot. Right, this becomes the pentology of Fallot. Now whatever he has been described here, that is she says that like squatting position relieves the bluish discoloration. So what exactly are these? So the patient is having cyanosis after feeding or crying, right? Why is that? That is mainly because of the apneic episode, right? And the patient may become even unconscious as well. And these are called TET spells. These are called TET spells. And these particular TET spells, they are relieved upon attaining the squatting position. Okay. Now, this is not acyanotic because there is a bluish discoloration. Your acyanotic is completely ruled out. Then you take the Eisenmenger's. See, in case of Eisenmenger's, what is that they will have is either ASD or VSD or patent ductus arteriosus, and there will be reversal of the shunt from right to left. That is what you will observe in case of the Eisenmenger's, and in case of Eisenmenger's, definitely there will be right ventricular hypertrophy. And the presentation of the patients with Eisenmenger's is that you don't have like this TET spells. Like upon attaining the squatting position, the bluish discoloration is getting relieved and patient is comfortable. That sort of history you don't have in case of the Eisenmenger's. They will present with cyanosis, and not only that, they will also have clubbing in clinical scenario of the Eisenmenger syndrome. So your Eisenmenger's is ruled out. Whereas you take Lutembacher syndrome. What is Lutembacher syndrome? Lutembacher syndrome, it is a congenital ASD. Along with the congenital ASD, the patient is having acquired mitral stenosis. Congenital ASD with acquired mitral stenosis. That is what is your Lutembacher syndrome, right? And in case of ASD, you don't have the cyanosis. You don't have the cyanosis. Okay. So the answer here is cyanotic congenital heart diseases, right? Now we'll move on to the next one. Right. Okay, so the other important area where the questions are being definitely asked is in the clinicals, in the murmurs. Okay, so murmurs is one important area. You should not go to the exam without revising them. So please revise the topic of murmurs before going to the exam. So we have a 45-year-old female presents to the cardiology clinic with complaints of dyspnea on exertion, orthopnea and paroxysmal nocturnal dyspnea. On examination, the physician notes a tapping apex beat and auscultates a loud first start sound, a mid-diastolic murmur that accentuates with presystolic accentuation. Additionally, a narrow split S1 is heard on auscultation. Which conditions are most likely responsible for the patient symptoms and examination findings? Yes, anyone? Right. So very good. So the answer here is the mitral stenosis. The answer is mitral stenosis. Now, what are the quick pointers suggestive of mitral stenosis? I'll tell you. Number one, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea. That you will see in all these manifestations. In all these, you will have the dyspnea on exertion, you will have paroxysmal nocturnal dyspnea and all. But what are the pointers to tell that it is mitral stenosis is the presence of loud S1, the presence of the mid-diastolic murmur, the presence of the pre-systolic accentuation. So these are the pointers suggestive of mitral stenosis. Now, whereas you take mitral regurgitation. In mitral regurgitation, what will be the findings? You will have soft S1, you will have a pansystolic murmur, you will have a wide split S2, right? You'll have a wide split S2, right? And in cases of the acute MR, there can be a functional mid-diastolic murmur also. There can be a functional mid-diastolic murmur in case of acute MR, that is in case of acute rheumatic carditis, and that is what we call it as a Carey-Coombs murmur. That is what is we call Carey-Coombs murmur. Whereas in case of the aortic regurgitation, what are the findings that you will have in aortic regurgitation? The first heart sound will be normal, but in second heart sound, you will have only P2. A2 will be soft or A2 will be completely absent in case of the aortic regurgitation. And the murmur that you will have is the early diastolic murmur that you will have in patients with the aortic regurgitation. And in case of the aortic regurgitation, apart from the early diastolic murmur, what are the other functional murmurs are? You have the Austin-Flint murmur, right? And you also have what is called Cole-Cecil murmur, right? And in case of the aortic regurgitation, there can be a functional ejection systolic murmur also can be there in patients with the aortic regurgitation, right? And in aortic stenosis, you will not have the mid-diastolic murmur. In aortic stenosis, the murmur that you will have is the ejection systolic murmur. And what are the other important auscultatory findings in case of the aortic stenosis is, in aortic stenosis, S1 will be normal, but if you take the S2, you will have a narrow split S2, right? You will have the narrow split S2, right? You will not have the normal S2. Yeah, Shiv Kumar, I'll explain you the pre-systolic accentuation. Just give me a 1 minute, right? And these patients, they will have narrow split S2, or they can also have a single S2 if the patient is having, right? There can be a single S2 if they are having what? If there is moderate or severe AS, there can be a single S2 as well, right? And in patients with the aortic stenosis, please remember the murmur will radiate to the apex, and that is what is called as the Galliverdin phenomena, right? That is what is called the Galliverdin phenomena. So Galliverdin phenomena is that where the murmur of the aortic stenosis will be radiating to the apex is what is called Galliverdin phenomena. Okay. Now this is the auscultatory finding in all these clinical scenarios. Now Shiv Kumar is asking me about presystolic accentuation. Let me just take up his point and then we'll move to the next question. So in patients with mitral stenosis, what will happen is, so how is the mitral valve? The mitral valve in case of the stenosis, you will notice that it is very much thick. Okay, it is very much thick. Okay, now if the mitral valve is very much thick, now if left atrium, if it contracts normally, do you think that the blood can be pushed into the ventricle? No. What the left atrium does, left atrium will give a very strong left atrial contraction, right? Very strong left atrial contraction in order to push the blood against the stenosed mitral valve. This strong left atrial contraction is what is nothing but your presystolic accentuation. And in which part of the cardiac cycle you will have this is, you will have this in the late diastole. Because you have this in the late diastole, which is exactly before the systole, that is why it is called presystolic accentuation. That is why it is called presystolic accentuation. Right. So this is about, right. So now where is that you will have the paradoxical S2, right? Yes, in case of very severe AS, right? Very severe AS, you will have paradoxical S2. What do you understand by this word paradoxical S2? You will have P2 followed by that A2. P2 followed by that A2. That is called paradoxical S2. That will be there in case of very severe aortic stenosis. Okay. Shiv Kumar, I hope you are done. Right, good. Now we'll move on to the next question. So the point I want to tell you is heart sounds and cardiac murmurs, valvular heart disease, very important area for the discussion just before going to your exam. Okay. Now, right. So you see this next question. So we are having a 45-year-old male presents to the clinic with history of gradual worsening high blood pressure. He reports experiencing frequent headache and occasional dizziness. Right, frequent headache and occasional dizziness. And he has a history of renal disease. On examination, the patient is overweight and has central obesity. Laboratory testing shows hypertriglyceridemia and low HDL. Which of the following secondary causes of hypertension is most likely responsible for the patient's condition? Obstructive sleep apnea, chronic kidney disease, renovascular hypertension, metabolic syndrome. Yes. So now if you take the clinical scenario, what is he asking is, he's asking which of the following is the cause for secondary cause for the hypertension, right? All of the options which has been given to you are suggestive of secondary causes for hypertension. And what is the most common cause for secondary cause for hypertension is the chronic kidney disease among the options which has been given to you, right? And yes, very good Gajendra and yeah Tarun, right, all of you who are answering these correct, very good Shivakumar. The answer is the metabolic syndrome. Now why is it metabolic syndrome? Because what is the criteria that you require for metabolic syndrome? Number one, central obesity, right? So this particular patient is having a very high BMI, so central obesity is there. That is one point which is there for you. And second important thing in the right, second important thing what is required is the hypertriglyceridemia, that is dyslipidemia, and there should also be low HDL as well. There should also be low HDL as well. And another important thing in the metabolic syndrome that you should be having is the presence of the hypertension. So the question itself is about the hypertension, right? The question itself is about the high blood pressure. So all the components of your metabolic syndrome is present in this case. Okay. And all the options which has been given to you are the secondary causes for hypertension. But if the question is asked to you what is the most common cause for hypertension, please remember the most common cause for hypertension is a primary hypertension or essential hypertension, which constitutes nearly around 85% causes for the hypertension, right? Only 15% will be your secondary causes for the hypertension. And in secondary causes, like you have renal parenchymal causes, you have renovascular causes, you have metabolic syndrome, obstructive sleep apnea, endocrine causes, and also you have some Mendelian causes. What are the Mendelian causes for hypertension? Mendelian causes for hypertension include Liddle syndrome, Gordon syndrome, polycystic kidney disease, pheochromocytoma, congenital adrenal hyperplasia. These are the Mendelian causes for your hypertension. Okay, so this is about the scenario of the hypertension. Right. Now, yes, and you should never miss the discussion related to the ischemic heart diseases. Right. Now, you see this question. We have a 56-year-old male presents with the severe chest pain and shortness of breath. His blood pressure is 150/90. The heart rate is 110 beats per minute. The respiratory rate is 22 breaths per minute. Oxygen saturation is 93% on room air. And significant ST segment elevation is present in lead 2-3 AVF are noted on the ECG. The drug given to treat him results in tachycardia, constipation, and cyanosis of skin, lips, and nail beds. Which of the following statements are true about this particular drug? Now, first of all, right. So, first of all, please tell me what the drug is this question talking about? What is this particular drug? The question is talking about tachycardia, constipation, cyanosis, and as well as the nail beds. Yes. So please remember, he is talking about the drug which is given in the treatment of the ischemic heart disease, that is the nitrates. that is nitrates. Now this particular nitrates, so the question is completely about the nitrates. Okay, now if you take these particular nitrates, where are they metabolized? Right, remember, it is the drug which is metabolized by the enzyme, that is the aldehyde dehydrogenase. It is metabolized by aldehyde dehydrogenase. And remember, this particular drug, that is nitrate, where all we use this in the treatment of the stable angina, we use this in the treatment of the prinzmetal angina, we use this in the treatment of the esophageal spasms, we use this in the treatment of the biliary colic, we use this in the treatment of the congestive heart failure, we also use this in the treatment of the hypertensive emergency. We also use this in the treatment of the hypertensive emergency. And you take the second option. Now, the patient will never develop tolerance to this particular drug. Remember, these nitrates, they are at increased risk of development of the tolerance. Okay, so tolerance can develop, leading to diminished therapeutic effect. So to prevent the tolerance, it is necessary to provide drug-free periods to avoid the desensitization of the vasodilatory response. Okay, and this, see, that we are giving the drug-free period, and the drug-free period we are giving to avoid the desensitization of the vasodilatory response, and this is what is called as the Monday's disease. Right, so this is what is called as the Monday's disease, the drug-free period that we are giving. Okay, and next is, it can be given, so your B is out, it can be given to a patient taking sildenafil for erectile dysfunction. Completely wrong. See, nitrates, they should never be given in a patient who is taking the sildenafil. What it can cause? It can cause a significant hypotension. So that is the reason why you should not give this particular drug along with the sildenafil. Okay, now it is a drug of choice for cyanide poisoning. That is a completely wrong statement. Now, what is a drug, or what is an important antidote that we give for cyanide poisoning is, we give hydroxycobalamin, right? We give hydroxycobalamin, or we give sodium thiosulfate. Hydroxycobalamin or sodium thiosulfate is what the drug that we give for the treatment of the cyanide poisoning. Okay, so this is about your nitrates. Now, what are the adverse effects of nitrates? See, the adverse effects of the nitrates is, it can cause cyanide poisoning, it can cause headache, it can cause flushing, hypotension, reflex tachycardia, and as well as constipation. Why there will be constipation? Because of decreased motility of the small intestine. And these particular nitrates, they are found to cause even methemoglobinemia as well. In certain cases of cyanide poisoning, they are found to cause the methemoglobinemia as well. Okay, and whenever you are giving nitrates, please remember, the drug that should be completely avoided is sildenafil should be avoided. Okay, so this is about the story related to the nitrates. Right, now, yes, now we will take up some questions related to the endocrinology. Right, some questions related to endocrinology. So whatever we have discussed until now is the cardiology topics. You take some endocrinology topics. Now we have a 42-year-old presenting with primary care physician, 2-year history of persistent hypertension that has been refractory to multiple antihypertensive medications. She reports that the individual is having muscle weakness, frequent urination, and occasional palpitation. On examination, her blood pressure is elevated. Laboratory investigation revealed hypokalemia, elevated plasma aldosterone concentration, and suppressed plasma renin activity. To further evaluate this patient, a salt loading test is performed. Which of the following results is most consistent with the suspected diagnosis of the patient? Right, yes, Krishna, thank you very much, and congratulations for clearing your USMLE on the first attempt. Yes, anyone? Right, so what is this question suggest you about? So the individual is having significant hypokalemia, and if you take the plasma aldosterone concentration, it is elevated, and there is suppressed plasma renin activity. So what has happened to your aldosterone renin ratio now? The aldosterone renin ratio is decreased, and there is also significant hypokalemia. So where do you come across this? You come across this in cases of primary hyperaldosteronism. In primary hyperaldosteronism, you come across this scenario of decrease in the aldo. Yeah, so I'm sorry. What will happen to your aldosterone renin ratio in case of primary? I'm very sorry. It is increased. So because renin will be reduced, aldosterone will be increased. So aldosterone renin ratio will be increased. Now, what is the investigation of choice? Actually, your aldosterone renin ratio, it is just only a screening test. Right, it is just only a screening test. Then what is the investigation of choice in case of your primary hyperaldosteronism? The investigation of choice is there will be a significant increase in plasma aldosterone concentration after salt loading, right? So after salt, in spite of salt loading, the aldosterone level increases. So what is this primary hyperaldosteronism now? It is your Conn syndrome. Okay, so if the question is asked, what is the most common cause for Conn syndrome? The answer should be adrenal adenoma. But if the question is asked, what is the most common cause for primary hyperaldosteronism? The answer should be bilateral adrenal hyperplasia. Right now, these patients, they will be having diastolic hypertension. But very, very important point, please remember, in case of Conns, there is no edema. Right, there is no edema. Right, and in fact these patients will have the polyuria. And why is this due to? This is due to a phenomena called the aldosterone escape phenomena. So due to aldosterone escape phenomena, you will have no edema and there is polyuria in these patients. All right, and apart from these, the other electrolyte abnormalities that these patients will be having is the hypokalemia will be there. And what does the ABG shows? The ABG, it will show you that there is metabolic alkalosis. The ABG will show you that there is metabolic alkalosis. And the screening test is what? The aldosterone renin ratio, which will be increased. And investigation of choice is what in case of the Conn syndrome? That is oral salt solution test. Now, apart from the oral salt solution test, the other investigations that that can be done for confirmation is the IV saline suppression can be done. Right, IV saline suppression can be done, or the other investigations are captopril challenge test. Right, captopril challenge test. And another important investigation is the fludrocortisone suppression test. So these are the investigations that you'll be doing for confirming this particular Conn syndrome. Then how do you treat these patients with the Conn syndrome? Please remember, surgical resection is the treatment of choice, right? And if you take the medical management in these individuals, if at all, if there is bilateral tumor or bilateral tumors causing your hyperaldosteronism, we don't do surgical resection. If there is bilateral tumors, then what we do is we give medical management. And what is that medical management that we give is spironolactone. And this particular spironolactone, it is an aldosterone antagonist. And with spironolactone, the tender gynecomastia is an important adverse effect. And in order to avoid this particular tender gynecomastia, like what is that you need to provide? You need to provide the eplerenone. Okay, so that is another important aldosterone antagonist, spironolactone and as well as eplerenone. So spironolactone, if it is causing tender gynecomastia, you can give eplerenone. Okay, so this is about the clinical scenario related to your Conn syndrome. And you need to know the very important differential diagnosis for your Conn syndrome. The important differential diagnosis Conn syndrome is your Liddle syndrome. Liddle syndrome is a very, very important differential diagnosis. Liddle syndrome is a very, very important differential diagnosis. And what exactly is your Liddle syndrome? It is a scenario where there is gain of function of the ENaC channels. And in case of Liddle syndrome, the drug that we give is the amyloid. The drug that we give is amyloid. Okay. Right. Now we'll move on to the next important clinical scenario. We have a 28-year-old woman. She presents to the emergency department with complaints of numbness and tingling in her hands and around her mouth. She reports feeling lightheaded and having muscle cramps in her legs. The patient has been experiencing increased anxiety and has been hyperventilating due to stress. On examination, her respirations are rapid and deep. Chopstick sign is positive. The facial twitching noted upon tapping her facial nerve. The rest of the physical examination is unremarkable. Which of the following is the most likely explanation for the patient's symptoms? Yeah. Yes, please answer this question. Very good. So now this particular individual will develop respiratory alkalosis. This patient will develop respiratory alkalosis, right? And it is because of respiratory alkalosis you will get the above clinical scenario. Now, first of all, why there is respiratory alkalosis? Because the patient is hyperventilating due to stress. That is what is causing the respiratory alkalosis. Now, whenever there is respiratory alkalosis, please remember there will be decrease in the quantity of, right, there will be decrease in the quantity of the ionized calcium. There will be decrease in the quantity of ionized calcium. Why is that? Because this ionized calcium will bind with albumin during or in the scenario of the respiratory alkalosis, right? So once there is increased binding of the ionized calcium with albumin, what will happen to your bound form of the calcium? Your bound form of the calcium increases, but what will happen to your ionized calcium? The ionized calcium decreases. The ionized calcium decreases. So when your ionized calcium is decreased, you will have all the features suggestive of your hypocalcemia. So whatever has been given to you here, that is complaints of numbness, tingling in our hands, surrounding the mouth, and as well as the individual having Chostek sign positive, right? All these are features suggestive of your hypocalcemia, and you will have this hypocalcemia, right? You will have this hypocalcemia, right, mainly because of your respiratory alkalosis. Okay, now at the same time I'll just give you a quick picture of your hypocalcemia of other reasons. So hypoparathyroidism is another important clinical condition where you'll have the hypocalcemia. And this hypoparathyroidism, what are the various etiologies that we have? Acute hypoparathyroidism can be seen secondary to your thyroid gland dissection. Your hypoparathyroidism can also be seen secondary to your hypomagnesemia. Hypoparathyroidism can be seen secondary to your Digeot syndrome. Hypoparathyroidism can also be seen secondary to your radiation therapy to the neck. So any condition which is causing your hypoparathyroidism will cause hypocalcemia, and in hypocalcemia you will have all these manifestations. All right. So what is the treatment that you need to give in this individual who is having hypocalcemia? You need to give calcium gluconate. You need to give calcium gluconate. Okay. So the answer here is C. Right. Now, the another very important area where the questions, so one important area where you should concentrate before going to your exam is related to calcium related disorders. Calcium related abnormality, you need to be completely clear, right? Hypercalcemia, hypocalcemia, alkaline phosphatase levels, all these you need to be completely aware of. Okay, now coming to the next question. We have a 35-year-old male presents to the endocrinology clinic with history of multiple endocrine neoplasia along with characteristic physical features. Now, he reports a family history of similar endocrine disorders. On examination, the patient has the enlarged lips, a thickened tongue, a multiple neuromas on the mucosal surface of his lips, and conjunctiva. He also has marfanoid habitus with long limbs and hyperflexible joints. Laboratory investigation revealed elevated levels of calcitonin and as well as catecholamine levels. Based on this patient's clinical presentation, which chromosome is most likely to be involved in this patient? Very good. So, yeah, very good, Srihari. Right. So the answer here is chromosome 10. So what is this clinical scenario suggestive of? This clinical scenario, it is suggestive of your men 2. Now, can anyone tell me, is it men 2A or men 2B? Is it men 2A or men 2B? Srihari, is it men 2A or men 2B? So please remember, it is not men 2A. It is meant to be, right? Why is that I am telling using the word this meant to be? Presence of the neuromas, presence of multiple neuromas, that is one point suggestive of your meant to be. And the other point is the marfanoid habitus. You'll have that in case of men 2B, not in case of men 2A. In case of men 2A, the extra endocrine manifestations will be in the form of the amyloidosis. Extra endocrine manifestations can be in the form of the Hirschsprung disease. But these patients with men 2A, they don't have this marfanoid habitus. Okay, so the answer is men 2B here, right? Now, in case of either men 2B or you take men 2A, right? In both of them, the abnormality is in chromosome number 10, right? And in which type of men syndrome you will have abnormality in chromosome 11? Which type of men syndrome you'll have the abnormality in chromosome 11? So the abnormality in chromosome 11, it is observed in case of men 1, right? Observed in case of men 1, right? And in which clinical scenario or in which syndrome you have abnormality on chromosome 12? So you have the abnormality on chromosome 12 in case of men 4, right? Men 4. And you need to quickly remember the genes as well. In case of men 1 syndrome, the gene that is being mutated is men 1 gene, which is a tumor suppressor gene. Whereas in men 2A and men 2B, the gene that is being mutated is the RET proto-oncogene. Whereas in case of men 4, the gene that is being mutated is CDKN1B. Right, CDKN1B. That is the gene that is being mutated in case of your men 4. Okay, and whatever he is giving you, that is your multiple endocrine, right? Elevated calcitonin is there and elevated catecholamines are there. What does it suggest you of? The elevated calcitonin levels, that is suggestive of the medullary carcinoma of thyroid, and this elevated catecholamine levels, this is suggestive of your pheochromocytoma. This is suggestive of your pheochromocytoma. Okay, so this is about, so the quick discussion is related to your men syndromes. Just before going to your your INICET exam, please quickly recap all the men syndromes. What are the endocrine tumors? What are the genes mutated? On which chromosome you have those particular genes, right? Now we'll take the next question. Okay, so we have a 62-year-old male. Now what is he presenting with? He is presenting with history of the type 2 diabetes mellitus. He presents to the clinic for routine follow-up appointment. He reports experiencing blurred vision and occasional episodes of double vision. On further inquiry, the patient mentions numbness and tingling sensation in the feet, as well as episodes of dizziness and difficulty in regulating the body temperature. His current medications include metformin and as well as the insulin. The fundoscopic examination reveals dot blot hemorrhages and as well as the cotton wool spots. Which of the following complications is the patient most likely experiencing? Yeah. Yes, anyone please answer this? Yes. Right. So this particular individual, right. So this individual is having, so which of the following is the most, see, he is experiencing blurring of vision and he is also having double vision, right? He is also having double vision. And along with that, okay, tingling and numbness, everything is there, and difficulty in regulating the body temperature. So what is this patient developed? This particular patient is first having diabetes mellitus. That is the first point. And upon that, he has now developed the autonomic neuropathy. He has now developed the diabetic autonomic neuropathy. Now, see, in diabetic autonomic neuropathy, you will not have reflex bradycardia, right? You will have resting tachycardia. right? You will have resting tachycardia. That will be there in case of autonomic neuropathy. What about gastroparesis? Can it be there? It can be there. But is this particular patient presenting with the gastroparesis manifestation? Is he presenting with any diarrhea? Is he presenting with any constipation? No. He is presenting with visual abnormalities. Fundoscopy is also showing that there is blot hemorrhages, cotton wool spots. They are suggestive of your diabetic retinopathy. And in case of diabetic retinopathy as a part of autonomic neuropathy, these patients, they will have a defect in controlling the pupillary response. Right? Once they develop autonomic neuropathy, they will have defect in controlling the pupillary response. And because of defect in controlling the pupillary response, that will lead to meiosis. They will not have the mydriasis here, they will have the meiosis. Okay, so the answer here is the meiosis. It is not the gastroparesis. Why? Because the patient presenting symptom is very, very important here. So the patient presenting symptom is what? The visual abnormalities. So that is the reason why the answer is meiosis here. Okay, whereas in autonomic neuropathy, you will have the very important characteristic feature is the postural hypotension, right, where the systolic blood pressure will fall by more than 20 millimeters of mercury and diastolic blood pressure will fall by more than 10 millimeters of mercury, right? And what is the drug of choice in case of postural hypotension? The drug of choice in case of postural hypotension will be midodrine. We give an alpha agonist, that is midodrine. That is a drug of choice in case of the postural hypotension. So that is secondary to your autonomic neuropathy, right? And secondary to your diabetic autonomic neuropathy, what are the other manifestations? These patients can develop silent MI that can lead to sudden death in diabetic patients. The other points are there can be hypoglycemia unawareness because of your diabetic autonomic neuropathy. And because of diabetic gastroparesis, there can be diarrhea or there can be even constipation also, right? And if there is diarrhea, the drug that is being used is clonidine. So if it is vagal action is dominating, diarrhea will be there. If the sympathetic action is dominating, they will have constipation. Okay, so the answer here is the meiosis here, right? Next. Yeah, so basically what I wanted to tell you now, I wanted to tell you that in case of diabetes, complications of diabetes very, very important for your INICET exam, right? Now, the next question. A 55-year-old male presenting to the clinic with fatigue, dizziness, and frequent episodes. On physical examination, the physician noticed a ruddy complexion and palpates an enlarged spleen. Laboratory investigations reveal elevated red blood cell count, the increased hemoglobin, and elevated erythropoietin level. The genetic analysis, this is very important. Genetic analysis reveal mutation signaling pathway involved in hormone regulation. Which of the following additional symptoms is expected to be seen in this patient? Yeah. Yes. So what is this clinical scenario suggestive of? So now the patient is having a mutation in the signaling pathway, right? Now what is that particular signaling pathway? So the signaling pathway mutation is nothing but it is a JAK-STAT pathway, right? It is JAK-STAT pathway. So the question says very clearly reveals a mutation in signaling pathway involved in hormone regulation, and whenever there is upregulation of the JAK-STAT pathway, whenever there is upregulation of the JAK-STAT pathway, please remember what are the hormones which are like act through this JAK-STAT pathway. The hormones which will be acting through JAK-STAT pathway is growth hormone, and the next one is the prolactin, right? Why is that the patient having ruddy spleen, ruddy complexion like spleen, that to enlarged spleen? Because there is increase in the activity of your growth hormone that can cause ruddy complexion and palpation of the enlarged spleen. And the other features whatever has been given to you are suggestive of your abnormality related to growth hormone, and you will also have the features because of increase in the prolactin now. So what will be the features due to increase in the prolactin level? That will be your galacturia. So this particular patient will have galacturia as the additional manifestation. Why? Because the genetic analysis revealing mutation in the signaling pathway, what is that? That is your prolactin and growth hormone. So because the prolactin is also being metabolized by your signaling pathway, that can result in the development of galacturia. That can result in the development of galacturia. All right. Now you see the next question. Okay. So we are having, right, we are having a 22-year-old woman comes to the office complaining of palpitations, weight loss, and insomnia. Experienced weight loss almost 7 kgs in the past 3 months. The patient is otherwise healthy with no medical problems and does not take any medication. She denies tobacco, alcohol, or illicit drug use. On examination, her blood pressure is 130/80, pulse rate is 104 per minute and regular. Thyroid gland is diffusely enlarged but non-tender on palpation. Laboratory test reveals significantly decreased serum TSH level and elevated thyroxine levels. Methimazole monotherapy is initiated and after 2 months, the patient's symptoms have resolved. Which of the following process is most likely directly inhibited by this? Yes, anyone? Right. So now the methimazole is the one which the patient is taking. So whenever the methimazole is given, whenever the methimazole is given, please remember methimazole will inhibit the thyroid peroxidase activity. Methimazole will inhibit the thyroid peroxidase activity. It's a thyroid peroxidase inhibitor. Now, let me also just give you a quick discussion related to your methimazole. Methimazole is a drug of choice in non-pregnant individual and as well as males. But methimazole cannot be given in case of the first trimester of the pregnancy because methimazole is associated with teratogenicity, that is aplasia cutis and as well as the choanal atresia. So that is the reason why methimazole cannot be given in the first trimester of pregnancy. Then what is that we give in the first trimester of pregnancy? In the first trimester of pregnancy, we give propylthiouracil, and in second and third trimester, we give methimazole, right? Then does it inhibit the TSH production? No, it will not inhibit the TSH production. And next is the sodium iodide symporter function. Now, what are the group of drugs which will inhibit the sodium iodide symporter function are thiocyanate, right? Thiocyanate, these are not used these days, but thiocyanate, they are the one which will inhibit the sodium iodide symporter, and thereby they inhibit the iodide transport into the thyroid gland and thereby reducing the thyroid hormone synthesis. Which one? Your sodium iodide symporter inhibitors, that is thiocyanate. And thyroglobulin synthesis is not being affected by your methimazole. So if you quickly see this table, right? So this is the list of your anti-thyroid drugs. Thionomides are methimazole and as well as propylthiouracil. The iodide solutions are your potassium iodide, Lugol's iodine. Where do we use this potassium iodide and as well as Lugol's iodine is, we mainly use them just before the thyroid surgery in case of toxic multinodular goiter. Just before surgery in case of toxic multinodular goiter, when we use this potassium iodide or sodium iodide or your Lugol's iodine, they act by Wolff-Chaikoff effect. They inhibit the thyroid hormone synthesis, right? And they also reduce the vascularity of the gland and they reduce the gland size. Which one? Your potassium iodide and as well as Lugol's iodine. So these particular, the iodide solution, they will reduce the gland size and they will ensure that thyroidectomy is being done. So that is about your potassium iodide and as well as Lugol's iodine. And you take this iodine 131, when the medical management is a contraindication, we can use this radioactive iodine. So this will emit the beta rays and it will cause the destruction of the thyroid gland. And thiocyanates, this your these cyanides we are not using these days, but these are the one which will inhibit the iodide transport into the thyroid gland, reducing the thyroid hormone synthesis. Okay, so this is about your anti-thyroid drugs. And at the same time, you need to quickly remember the methimazole adverse effect. The adverse effects of methimazole, it will cause agranulocytosis, And because of this agranulocytosis, what will the patient presentation will be? The patient's presentation will be in the form of the upper respiratory tract infections. In the form of upper respiratory tract infections. Okay. So that was about the discussion of the antithyroid drugs. Okay. Now you see the next important question. That is, kidney transplantation is one important area where the questions are being frequently asked in the INICET exam. Kidney transplantation and as well as liver transplantation. So please quickly revise your kidney transplantation topic just before going to the exam. Yes. So this is the question. Please answer this. Yes. So pick the option with appropriate statement regarding allogenic renal transplantation. So prior Doppler showing unilateral renal artery stenosis is the donor, is a contraindication. The right kidney of the donor is used. The donor kidney is placed in the right iliac fossa of the recipient. The recipient with 3/6 HLA match anti-CD25 is used for the induction therapy. Right. So what is the correct answer? C and D. The donor's kidney is placed in the right iliac fossa. That is, this C is correct. And definitely we do a prior Doppler showing unilateral renal artery stenosis. So prior Doppler showing unilateral renal artery stenosis in a donor is a contraindication. Why? If suppose if the donor is having the renal artery stenosis, you cannot take that particular kidney from the donor, or suppose which particular kidney of the donor we take the left kidney from the donor. Let us just assume if the right kidney of the donor, if it is having renal artery stenosis, we cannot take the left kidney from the donor, because once you take out the left kidney, your right kidney is also under the great insult due to renal artery stenosis. So that is the reason why if there is renal artery stenosis in the donor, you cannot take that particular kidney. That becomes an absolute contraindication. And right kidney of the donor is used? No, it is not the right kidney, it is the left kidney of the donor that is being used. And why is it left kidney of the donor being used? Is left kidney is having a longer renal vasculature. That is the reason why we take out the left kidney from the donor. The donor kidney is placed in the right iliac fossa of the recipient. Yes, the donor kidney is being placed in the right iliac fossa. We don't place it in the loin area. We don't place it in the retroperitoneal area. We place it in the right iliac fossa and we anastomose with the iliac vasculature of the recipient. And in recipients 3/6 we use the anti-CD25. See, what is this particular anti-CD25? The anti-CD25 is basiliximab. Right, it is your basiliximab. And this basiliximab, we give this as an induction therapy when the HLA is 2/6. When the HLA is around 2/6, then we use the basiliximab as the induction therapy, not 3/6 HLA match. Okay, so then what will be the correct answer now? That is your A and C is correct, which is nothing but your option A. And as and when you place the kidney, what is that you are very much worried about is the immune rejection. So for immune rejection, we give the induction therapy and we also give a chronic maintenance therapy. That is your cyclophosphamide, azathioprine and prednisolone is what need to be given in the patients with the kidney transplantation. Okay, right. Moving to the next question. Okay, so we are having a 55-year-old male presents to the clinic with complaints of recurrent episodes of the flank pain, right flank pain over the past few months. Upon further questioning, he mentions a family history of kidney problems with his father having been diagnosed with a renal cyst. The physical examination revealed bilateral tenderness at the costovertebral junction. Laboratory investigation showed a mildly elevated serum creatinine level. Which of the following is true regarding the genetic cause of this condition? So these days the options are not like a single word. The options are like being very lengthy options. You need to have little patience in going through all the 4 options. Yeah, please answer this question. Very good, Dr. L. So the answer is your PKD1 gene encoding for polycystin 1 on the chromosome 16. So what is this clinical scenario suggestive of? This clinical scenario, it is suggestive of the polycystic kidney disease. And in polycystic kidney disease, the genes that are being mutated are the PKD1 gene and as well as the PKD2 gene is being mutated. And the PKD1 gene, it is present on chromosome 16 and PKD2 gene, it is present on the chromosome 4. And this PKD1 gene, it will code for the protein that is polycystin 1. This will code for the protein that is polycystin 1, whereas PKD2 gene, this will code for the protein that is the polycystin 2. That will code for the protein that is polycystin 2. Okay, and because of these gene mutations, the individual will develop a polycystic kidney disease, and the type of inheritance that you will have is an autosomal dominant type of inheritance, what you will see in this scenario in adults, whereas in children you will have what is called as an autosomal recessive type of inheritance is present in case of children, whereas in adult polycystic kidney disease, it is autosomal dominant type of polycystic kidney disease. And what will be the common clinical presentation in these patients? Because there is enlargement of the kidney, there is stretch of the fascia of the gerota, that will result in the pain in the loin area. So these patients will present with recurrent flank pain, and not only that, these patients, they are also at increased risk of uric acid stones. So uric acid calculi is very common in patients with the polycystic kidney disease. Even that also contributes to the loin pain or the flank pain. And these patients with polycystic kidney disease, they also develop hypertension. Almost 75 to 80% of patients with polycystic kidney disease, they will have the hypertension. Okay, and the other important point is these patients with polycystic kidney disease, they are at increased risk of the urinary tract infection, and if at all, if the cysts are being infected, they will have an acute pain. That is very important that you need to know. And next is, how will you investigate these patients? The investigation is by your ultrasound abdomen. So ultrasound abdomen is the one which will tell you the number of cysts, but the confirmation can be done by your CT of the abdomen, right? And how can you prevent the progression of this polycystic kidney disease? Is you can prevent the progression of the polycystic kidney disease by giving the everolimus, right? So everolimus is the drug which can be given to prevent the progression of your polycystic kidney disease. Then for the other things, like for example, the patient is having severe loin pain. What is the reason? Because of the enlargement of the kidney. So what you need to do is you need to plan for a partial nephrectomy has to be done, right? A partial nephrectomy has to be done. And these patients with polycystic kidney disease, please remember, they are also associated with extrarenal manifestations. The cysts are not just confined to the kidney, the cysts are present also in the liver, cysts are also present in the pancreas, cysts are also present in the ovaries. Extrarenal manifestations are also present in these individuals. And second important thing that you need to know is these patients, they are at increased risk of berry-aneurysms. When they rupture, they develop subarachnoid hemorrhage. Then these patients, they also have gastrointestinal abnormalities in the form of the presence of the gastrointestinal polyps. And next is cardiovascular abnormality can be there in patients with polycystic kidney disease, that is in the form of mitral valve prolapse. Okay, so these are the extrarenal manifestations that you will have in patients with polycystic kidney disease. Okay, so this is in nutshell about the polycystic kidney disease. Right, so please answer this quickly. This is a very simple question if I am not wrong. Using the two images below, identify the type of acute kidney injury. Is it a chronic kidney disease? Is it a pre-renal type of acute kidney injury? Is it a post-renal type of acute kidney injury? Or is it a renal type of the acute kidney injury? Yes, right. So what are you observing here? This cutaneous manifestation, we call this as livedo reticularis, right? We call this as livedo reticularis. That is one point. And next is, you can see this, there is presence of an emboli. There is presence of emboli even into the retinal circulation. And what are these called? These are called as Hollenhorst plaques, right? These are called the Hollenhorst plaques. Okay, so Where do you have these, the livedo reticularis and as well as the Hollenhorst plaques are, they are present in case of atheroembolic diseases. Right, they are present in cases of the atheroembolic diseases. Okay, so in now if you take this atheroembolic disease will cause acute kidney injury. What type of acute kidney injury it will cause? This will cause a pre-renal type of it will cause renal type of acute kidney injury, right? That is what is your atheroembolic disease. Then how will you diagnose or how will you confirm this atheroembolic disease is, you will be able to confirm that atheroembolic disease by the presence of the eosinophilia, right? And you will be able to confirm this atheroembolic disease by the presence of the eosinophiluria, right? So you will be able to confirm that by eosinophilia and as well as the eosinophiluria. Which one? The atheroembolic diseases, right? Which will cause the renal type of acute kidney injury. It is not your pre-renal type of acute kidney injury. So if you see the other options, like most common cause of chronic kidney disease is what? Most common cause for chronic kidney disease, that is your diabetes mellitus. And what is the important problem in case of pre-renal? Perfusion to the kidney will be reduced, and perfusion to the kidney will be reduced in multiple reasons. Congestive heart failure, right? Or any condition which is decreasing the cardiac output. Second, decreased fluid volume in the body. That is second option. Third, your renal artery vasoconstriction. A renal artery vasoconstriction can be seen in case of sepsis, hypercalcemia, and hepatorenal syndrome. Fourth, drugs causing impairment of autoregulation. Drugs causing impairment of autoregulation, that is done by your NSAIDs and as well as ACE inhibitors. So all these, they lead to the pre-renal type of acute kidney injury. Whereas the post-renal type of acute kidney injury, if you observe, post-renal type of acute kidney injury, it is the causes include the renal calculi or bladder calculi or benign prostatic hyperplasia, which is the most common cause in the males, right? Or bilateral ureteric fibrosis seen in case of scleroderma or caused by your bleomycin. These are your post-renal causes. And one more important, renal vein thrombosis. So these are the causes for the post-renal type of acute kidney injury. Whereas atheroembolic diseases, they will cause the renal type of acute kidney injury, right? So the next question is, right. So you see the next question. We have a 60-year-old male patient with a history of hypertension and as well as diabetes mellitus. Presents to the emergency department with complaints of decreased urine output and as well as the generalized weakness. Urine analysis reveals the presence of muddy brown granular cast. What is the most likely diagnosis based on these findings? The options are the acute kidney injury due to acute tubular necrosis, chronic kidney disease exacerbation, urinary tract infection, and then the nephrotic syndrome. Yes, so what is the answer? Very good. So here the answer is your A. The answer is A. So what is that telling you? It is your acute kidney injury due to acute tubular necrosis. The very important pointer is your muddy brown granular cast. So now what are the causes for your muddy brown granular cast causing acute tubular necrosis? You will see this in case of myoglobinuria. Right? You will see this in cases of hemoglobinuria. Okay, so in myoglobinuria and as well as hemoglobinuria, you will have the acute tubular necrosis where you have the presence of a muddy brown cast. Where you have the presence of muddy brown cast. Okay, whereas you take the features of the other options which has been given to you, right? So in case of the CKD, what you can have is the presence of the waxy cast, right? And it is not always common, plus minus. And urinary tract infection, you will have WBC cast, right? Whereas in case of the nephrotic syndrome, you will have the presence of the fat bodies in the urine. right? You can, because these patients, they are having hyperlipidemia, and that hyperlipidemia will cause lipiduria. So in nephrotic syndrome, you will have the presence of the fat bodies in the urine sample, right? So the answer here is what? The acute kidney injury due to the acute tubular necrosis. Actually, your acute tubular necrosis, this is one of the leading cause for the development of intrinsic type of acute kidney injury. So what is this now? This will be causing renal or intrinsic type of the acute kidney injury is what you will observe here, right? So the answer is A. Now, next followed by that, yes. So you see this question, we're having a 40-year-old male who is known case of the HIV, came to outpatient department with complaints of headache and frothy urine. General examination shows that he was pale, had pedal edema, and blood pressure of 140 by 100 millimeters of mercury. Laboratory investigation showed more than 3 RBCs and deranged glomerular filtration rate. Ultrasound guided kidney biopsy showed that there is segmental obliteration or the segmental obliteration of the glomerulus on light microscopy and E-phase podocytes accompanied by vacuolization and detachment on the electron microscopy. Identify the type of nephrotic syndrome and mark the right option. So the options are, yeah, so the options are the focal segmental glomerulosclerosis, then membranous, minimal change, finish type. Um, it is not minimal change disease. Why? Because minimal change disease, it is commonly observed in children, right? And you will not have hematuria, right? There you will not have hematuria. Our patient is having 3 RBCs per high power field, right? Which is your microscopic hematuria, which is not seen in case of minimal change disease, right? So your minimal change disease is like completely ruled out. Now, according to the age, according to the biopsy finding, according to the age and as well as according to the biopsy finding, there is segmental obliteration of the glomerulus on the light microscopy and E-phase podocytes accompanied by vacuolization and detachment on the electron microscopy. So this is suggestive of your focal segmental glomerulosclerosis. This suggests you of FSGS. Now, among all the forms of nephrotic syndrome, the type of nephrotic syndrome which is seen in case of the adults where there is hematuria is your focal segmental glomerulosclerosis, right? Now, then next important is membranous glomerulopathy. What will be the findings in membranous glomerulopathy? First of all, membranous glomerulopathy, it is present in elderly individuals, age around 6th decade of life, right? And in membranous glomerulopathy, you don't have the detachment of the podocytes and you don't have the vacuolization of the podocytes and you don't have the effacement of the podocytes in case of the membranous glomerulopathy. So in case of membranous glomerulopathy, like what is that you will have is, in membranous glomerulopathy, please remember, there will be a thickening of the basement membrane, right? Thickening of the basement membrane will be there. And next important is, when you observe the same under the electron microscopy, you will notice that there is a subepithelial deposits, right? And this subepithelial deposits, it can be observed as spike and dome appearance in case of the membranous glomerulonephritis, right? It can appear as spike and dome appearance in case of membranous glomerulonephritis. And when you do a fluorescent microscopy in membranous glomerulonephritis, you will notice that there is IgG and as well as C3. So that is what is the picture that you will have in case of the membranous glomerulopathy. Whereas minimal change disease, it is commonly observed in children, and in minimal change disease, you don't have the vacuolization and detachment of the podocyte. You will have only effacement of the podocyte will be there in case of minimal change disease, and that too in electron microscopy. Whereas how will be the light microscopy in these individuals with minimal change disease? No change, right? It appears normal in light microscopy, but what it gives here, there is obliteration of the glomerulus on light microscopy, so that will completely rule out your minimal change disease, right? Then Finnish type of nephrotic syndrome. So Finnish type of nephrotic syndrome, that is your congenital nephrotic syndrome. right? That is your congenital nephrotic syndrome. So congenital nephrotic syndrome is called as the Finnish type of the nephrotic syndrome. And can anyone tell me what are the genes that are being defective in case of your Finnish type? In congenital nephrotic syndrome, what is the genes that are being defective? So in case of the congenital nephrotic syndrome, you have zipper genes. That zipper genes are what are being defective in case of the Finnish type. Yes, so that will be your the NSP gene that is being defective. So that is about your so the very important part of the discussion that you need to know is you need to revise your nephrotic syndrome before going to your INICET exam, which is a very important topic. Right. Next one. We have a 55-year-old male with a history of poorly controlled diabetes mellitus presenting to the emergency department with weakness, palpitations and muscle cramps. Laboratory test reveals hyperkalemia and metabolic acidosis. Further investigation confirm the diagnosis of type 4 renal tubular acidosis. Which of the following treatment options would be most appropriate to manage the underlying electrolyte abnormality of this patient? Which of the following treatment options would be most appropriate? So the clinical picture is what? The clinical picture is suggestive of your type 4 renal tubular acidosis. Yes, what is the drug that we give in case of type 4 renal tubular acidosis? So the drug that we give in the treatment of a type 4 renal tubular acidosis will be, drug of choice will be fludrocortisone. The drug of choice in case of the type 4 renal tubular acidosis will be fludrocortisone. Okay, so fludrocortisone will be having an aldosterone like action. It's a synthetic mineralocorticoid and it's a suitable treatment for your type 4 renal tubular acidosis, right? This fludrocortisone will have the action similar to that of your aldosterone, where you have an aldosterone deficiency in case of your type 4 renal tubular acidosis. So type 4 renal tubular acidosis is what? It is due to aldosterone deficiency, right? Or it is due to aldosterone resistance in case of your type 4 renal tubular acidosis, and you need to give a drug of choice, that is your fludrocortisone. Fludrocortisone is having a mineralocorticoid action. This will also cause sodium and water retention, potassium excretion, and as well as the H+ ion excretion. So that is how you will be able to achieve the electrolyte abnormality, right? So it is your fludrocortisone. And dietary potassium restriction, do we do? Yes, we do. But the drug of choice, that will be your fludrocortisone, right? And do we give furosemide? Plus minus. And do we give this sodium bicarbonate supplementation? Yes, we give sodium bicarbonate supplementation, but the primary drug that we need to give in the treatment of type 4 renal tubular acidosis will be fludrocortisone, right? That is the answer. Done. Next. Yeah. We have a 17-year-old male came to the outpatient department with complaining of high fever, vomiting, joint pains, and confusion for the past 3 days. The blood cultures revealed the kidney-shaped gram-negative bacteria and positive Kernick sign. Further investigations showed a dark orange-yellow urine with increased urinary sodium and reduced blood urea nitrogen and positive water loading test. Identify the condition and mark the option which is not the part of the diagnostic criteria. Which is not the part of the diagnostic criteria. So can anyone first crack the diagnosis? High fever, joint pains, confusion, blood examination showing kidney-shaped gram-negative bacteria, positive Kernicks, and the individual is having increased urinary sodium, reduced blood urea nitrogen, positive water loading test. What is the diagnosis? The question asked is what? The question is, which of the following is not the part of the diagnostic criteria? Right. So the diagnosis in the given clinical scenario, it is, the diagnosis is your SIADH. Diagnosis is SIADH. Now, can anyone tell me which organism the question is talking about? Which organism the question is about? kidney shaped diplococci, and that too a gram negative organism. That too a gram negative organism, right? Yes, so that is Neisseria meningitidis. That is Neisseria meningitidis. So Neisseria meningitidis, which is also called meningococci, that is what is the organism which is causing the SAADH in this patient. So does this Neisseria meningitidis does it cause? Yes, it does cause the development of the SAADH. Now, in patients with SAADH, what is that you will notice? You will notice that there is a decrease in serum osmolality. You will notice that there is hyponatremia, right? And you will notice that there is increase in the urine osmolality, and you will notice that there is also increase in the urinary sodium. So the clinical features like your confusion and all is mainly because of what? Is mainly because of the hyponatremia. Is mainly because of the hyponatremia, right? Vaidya. So do we call it as cerebral salt wasting syndrome? See, in patients with cerebral salt wasting syndrome, they will be having polyuria, right? In cerebral salt wasting syndrome, the important manifestation is polyuria along with that hyponatremia. But here the patient is having an infection. Secondary to that, there is development of these manifestations, which is suggestive of your SAADH. Okay, so in SAADH, there will be euvolemic status. In SAADH, it is euvolemic status. Okay, so the answer is clinical euvolemia. Plasma osmolality will be decreased. There will be normal thyroid function in these individuals, but timed 24-hour urine studies, right? Timed 24-hour urine studies is what we don't do in case of SAADH. How will you confirm this SAADH? The confirmation of the SAADH is by water loading test. The confirmation of the SAADH is by water loading test. Okay, so the answer here is the question asked is what? Not the part of the diagnostic criteria. That is your time of 24-hour urine studies. This is not used in the making out the SAADH. Okay, so the answer is D here. Done. Now, in case of SAADH, all the clinical manifestations, they are mainly because of hyponatremia. You will not have the fluid overload state in case of the SAADH. And in case of the SAADH, what is the drug of choice? Anyone? What is the drug of choice in case of the SAADH? Right. The drug of choice in case of the SAADH is Vaptans. And the first line treatment is 3% sodium chloride. 3% first line treatment is you need to ensure that the fluid has to be restricted by the individual. The fluid has to be restricted by the individual, and Vaptans have to be given, and 3% sodium chloride when you need to give if the individual is having clinical features due to hyponatremia. If there is clinical features due to hyponatremia, then we give this the 3% sodium chloride. And among the Vaptans, what are the Vaptans that we give? We give tolvaptan, and as well as the conivaptan is what we give. So your tolvaptan is a V2 receptor antagonist, whereas your conivaptan, it is both V1 and V2 receptor antagonist. All right. Next question. So, right, always there's one stock question asked from the water and as well as the electrolyte abnormality. I'll just give you one question. Please calculate. We have a 25-year-old male patient weighing 60 kg, right? 60 kg was brought to the emergency department in an unconscious state by the father, right? And his known case of diabetes insipidus. His laboratory report showed sodium levels of 158. Identify the electrolyte imbalance and calculate the volume of the fluid correction. Right. So please answer this fluid correction. So this question is what about now? The question is about the fluid correction. Just give me 1 minute. I'll be back. 1 or 2 minutes. I'll be back. Please correct the the fluid correction here. By the time I come back, right, I should be knowing the formula for the fluid correction. And please tell me the answer as well. Just give me 1 minute or 2 minutes. Right. So yeah, so you need to know how to calculate the, so now calculate the volume of the fluid correction. Now what is the formula for the volume of the fluid correction? So definitely you will be given one question with the formula oriented electrolyte correction, or this like this volume of the fluid correction. They'll be given, you'll be given one question, so you need to know how to calculate this. So formula for volume of the fluid correction is total body water of the individual multiplied by sodium, that is the actual sodium of the patient, minus 140 divided by 140. This is the formula for volume of the fluid correction. How do you get this total body weight? So total body weight in case of males, zero point 0.6 should be multiplied by body weight of the individual, right? 0. 0.6 should be multiplied by body weight of the individual. How much is the body weight? That is 60. So 0. 0.6 into 60, so that comes around 36. Okay, so now if you take 36 multiplied by actual sodium is how much? 158 minus 140 divided by 140. Okay, so you are getting around 360. So 158 multiplied by 18 divided by 140 is what you will get. So if you calculate this now, the value that you will get is 4.6 liters. The value you will get is the 4.6 liters. So what is the volume of the fluid correction in these patients? That is 4.6 liters is the volume of the fluid correction, right? So, and this patient is having hypernatremia. So what is that particular volume that you will give? What is the problem with hypernatremia? Hypernatremia will cause the fluid shift across the brain, and that can cause seizures. And what is the fluid? That 4.6 liters of the fluid, what fluid you are giving? So you have to give the half normal saline. The fluid of the choice will be the half normal saline, right? The half normal saline, right? Or the other option is that dextrose, 5% dextrose can be given, right? 5% dextrose can be given. Okay, so the answer is the 4.6 liters. Now what all could be the reason for the hypernatremia? You take extreme debilitation, geriatric age group, Alzheimer's, hip surgeries, or diabetes insipidus. So these are the scenarios where you can have the hypernatremia. Okay, so this is about the question related to hypernatremia. How to do the fluid correction, right? Very important question, very important question. Okay, now last question we will take up, and then we will wind up this session. Right, so one quick question related to the neurology. A 32-year-old female presents to the neurology clinic with history of recurrent episodes of blurred vision, weakness in her legs, and difficulty in coordinating the movements. She reports experiencing intermittent urinary urgency and frequency, along with occasional urinary incontinence. On examination, the patient demonstrates the signs of internal nuclear ophthalmoplegia. All of the following are associated with this condition except the INO 1.5 syndrome, 8.5 syndrome, detrusor hyporeflexia. Yes, right. So now this clinical picture suggests you of internuclear ophthalmoplegia, blurred vision, weakness in her legs, and that too in a female patient. And there is also intermittent urinary urgency and as well as frequency, difficulty in coordinating the movements. This picture is suggests you of your MS, multiple sclerosis. And in case of multiple sclerosis, there is demyelination of the median longitudinal fasciculus. So because of the demyelination of the median longitudinal fasciculus, they will have the INO, internuclear ophthalmoplegia will be present. And they will also have 1.5 syndrome, and they will also have 8.5 syndrome. But they will not have the detrusor hyporeflexia. What they will have is detrusor hyperreflexia will be there. Right, detrusor, the hyperreflexia will be there. Now, to quickly make a note on this, the 8.5 syndrome, see, 8.5 syndrome uh, is that where you will have the facial weakness, that is 7. Along with that, you will have the features of the 1.5 syndrome. Along with that, you will have the features of the 1.5 syndrome. So because 7 plus 1.5, it becomes 8.5. That is the reason why it is called 8.5 syndrome. And in 1.5 syndrome, what is the problem? You will have this horizontal diplopia. There is horizontal diplopia. So this is a case of multiple sclerosis wherein you will have internuclear ophthalmoplegia, you will have 1.5 syndrome, you will have 8.5 syndrome, but you will not have detrusor hyporeflexia. But what is that you will have is detrusor hyperreflexia is what you will have. Okay, so this is about your multiple sclerosis. So these are some of the important questions that I just wanted to take up before going to your INICET exam. And please remember, in case of INICET exam, the definite things that will be asked, ECG definitely will be there. Arterial blood gas analysis definitely will be there, right? And next is the questions on calculations definitely will be there. The fluid correction, that is mainly electrolyte abnormalities. So in a hyperkalemia, hypokalemia, hypernatremia, hyponatremia, definitely you will have a question on this electrolyte abnormalities. So you should not go to the exam without knowing the formulas which are required for the electrolyte abnormalities. And in cardiology, that very important is your murmurs, cardiac murmurs, and as well as, and you need to know the dynamic auscultation about these cardiac murmurs. What will happen to these murmurs, or what will happen to these valvular lesions upon doing the various maneuvers? So that you need to know. So these are some of the questions which I wanted to discuss just you before going to the INICET exam. And in the exam, be focused on the questions, rule out all the options thoroughly and properly. Don't be in a hurry while solving the questions. Stay completely focused, be calm, be cool. And it is not that easy to be, as I am saying, right? Because I am not writing the exam, but definitely it is the heat that you will be facing a lot. And I can sense the pressure that you will be having. But the only way that we can make out the exam very clearly without having any problem is by staying cool, calm, and focused during the examination time. So thank you very much, and I wish you all the very best. And I'm expecting that you'll be coming out of the examination hall with the flying colors. Thank you very much.